So bispecifics and CAR T cells are increasingly used in heavily pretreated myeloma patients. CAR T cells are now also approved in early lines of therapy. Soon, also bispecifics will be available based on the phase 3 studies that are ongoing in earlier phases of therapy. Also at last ESCO and in meetings before, we have learned that belantamab in combination with Veldex or in combination with Pomdex is a very effective combination in patients with earlier lines of therapy. So there is an influx of BCMA-targeted therapies into patients with 1 or 2 or 3 prior lines of therapy, not only CAR T cells and bispecifics, but also antibody-drug conjugates. So we have to learn much more about the ideal sequence of these agents. CAR T cell therapy seems to be most efficient if given as first option, and then hopefully after a long treatment-free interval, patients can then be rescued with other bispecifics, either targeting BCMA or targeting GPRC5D, and possibly also antibody-drug conjugates are effective after CAR T cells. However, all these studies looking at sequencing consisted of small subsets of patients, so we need more information. And it's also important that these studies also suggest that CAR T after belantamab or bispecifics, which are given continuously, is not the most efficient way to sequence these drugs. Of course, now that these BCMA-targeted agents are moving forward to early lines of therapy, we have to learn more about their side effects, infections with the bispecifics, cytokine release syndrome and neurotoxicity with CAR T. We have to learn about management of eye toxicities with belantamab. So we are also experiencing other side effects in early lines of therapy because of the continuously changing landscape of myeloma.